is a demo used by Microsoft and KenSci in Microsoft's technology centers, of which there are 36 around the world. In this demonstration, I play the role both of a chief medical officer or chief financial officer, as well as the role of an analyst. So, beginning as a chief medical officer, we're looking at a patient. His name was Bill Johnson. He came into our system, and we have created this narrative about Bill. So for many years, like many Americans, Bill felt he was pretty healthy and did not engage proactively with the healthcare system. However, beginning in 2011, he started feeling funny, feeling different than he had before, and went to see his general practitioner complaining of just discomfort in his heart, in his chest area. That time, the doctor told him he needed to change his lifestyle, stop smoking, exercise more, have a better diet, etc. But like many people, Bill ignored the doctor. Over the next 18 months, Bill was engaged more frequently on a reactive basis with his healthcare providers. This culminated in a heart attack in 2013. So he was taken by ambulance to the hospital. He was admitted to that hospital for 7 days for treatment of his heart attack. He was readmitted for 21 days with sepsis, let out, but had to quickly come back in for a final 3 days. At that time, an ejection fraction measurement was taken of his heart. Ejection fraction measures how efficient your heart is pumping blood. He was within the normal range, albeit on the low end. Bill returned from the hospital, but he was a changed man. He was much weaker and frailer than he had been before. He had one emergency visit. Finally, he went back to the hospital in 2016 with 2 4-day visits. Ejection fraction was very, very low, and Bill passed away in October of 2016. Now, Bill's story it's not a happy one, it's a sad one, and it's one that is repeated millions of times every year around the world. It highlights how reactive our most healthcare systems are, and how at any time in this process, we could have intervened more positively with Bill and taken a proactive stance in his treatment. What KenSci aims to do is to use data science to enable healthcare providers to work with their patients on a proactive and predictive basis to help them understand the control that they can exert over their own healthcare trajectory. So let's talk about how we might do that. KenSci provides a health analytics platform, which is just almost like a news site for healthcare. So in this view, I have data from the World Bank, which shows the national health expenditure as a percentage of GDP. The US, in this example, really stands out at being well above its other developed nations, with Sweden being down at 12%. If we were to click into this, we would see Singapore all the way down at 5%. Also show data from the CDC, which has US annual mortalities by cause. And here, diseases of the heart and cancer really stand out as being far above any other causes. Now, what we're looking at here is a Power BI dashboard. And what's a useful feature of the dashboard is how flexible it is in being able to easily display a lot of different types of media. So here I've included a YouTube video which talks about heart disease. And very interestingly, this video says that since the mid-2000s, heart disease has been on a very steady decline in the US. However, one element of heart disease has actually been increasing from around 2011 out through today. And that element of heart disease is CHF, congestive heart failure. We can explore what that looks like by using functionality from Power BI called Q&A. So here I have this heart failure mortality rate tile. When I click into this tile, it gives us a value of 166.3, which is essentially the 10-year average of heart failure in the United States. So this is heart failure deaths per 100,000 population. I can explore this data just using natural language and typing in by year. This will create a bar chart for me. So now we can see years 2006 through 2012. I'm going to say as line. And now we've expanded it out to calendar year 14. And then I'm going to start exploring in more detail, meaning going down to the state level. So if we look at California, California has a different profile, meaning a straight line downward trend until 2013 as opposed to 2012. We can add in another state, in this case, Minnesota. And you see Minnesota in 2009 actually started to increase. Another state which is similar profile and is Texas. And then let's get one more, and South Carolina. And so both Texas and South Carolina have these very elevated rates of heart failure, but in South Carolina, much higher than any of the other states we looked at. So it's very easy to see that this is a problem which is faced pretty broadly. Let's explore this in much more granular detail by going to Power BI Desktop. So Power BI Desktop is a app that sits on my hard drive. What we're looking at here is a map of the US with that heart failure line, and it's interactive. So if I select North Dakota, this line will then reflect a North Dakota value, etc. I also want to be able to map this not just at a state level, but at a county level. So I'm going to come to the heat map page. Here we're using the Esri mapping visualization, which is standard in Power BI, to look at where heart failure rates are highest, heart disease deaths are highest by county, and you see it centered here in the south. Now, this graph over on the left is essentially 5 buckets of heart failure mortality rates, where what I've shown is those counties which are increasing or decreasing in terms of heart failure mortality rates. So of the 33,000 counties in the United States, 1,200 are increasing, 700 from 0 to 10%, and 556 from greater than 10%. And so when we isolate these counties, there's this concentrated band that goes from the upper Midwest down through Appalachia and to the coast around Virginia, and then down the East Coast till you get to Georgia and northern Florida. Also can use the Sandance visualization, which is produced by Microsoft Research, to look at a lot more data. So here I have created heart failure buckets, with red being the highest bucket, and you can very easily see where heart failure is most centered in the US. Now I'm going to change this metric and look at some others. So I'm going to edit this and then open up this Insights panel. And so now I'm going to change my view, and I'm going to change the x-axis from longitude and the y-axis from latitude to diabetes, the percentage of the population which has diabetes, and the percentage of the population which is obese. So when I do that, what we see is a very clear correlation between diabetes and obesity and heart failure. So high heart failure counties are those red counties, and they are in the upper right of this rectangle, where obesity rates and diabetes rates are the highest. Now, I've also brought in data from the US Census, so we can look at this from a socioeconomic perspective. And if we change the y-axis to income per capita, the x-axis to poverty rate, we get a Nike type swoosh almost, where again it's very clear that those who are suffering from heart failure are very low on the income scale. So this is also a socioeconomic problem that we're facing in the United States. And if we're going to tackle it effectively, we need to consider these different cuts of our population. Finally, I was interested in looking at deaths from drug overdoses. So the other big scourge in the United States is opioid deaths. Here I have a map of heart failure deaths in 2015, and it's centered in some very concentrated areas. So Appalachia, Texas, Oklahoma, and Kansas, down here in the Southwest, particularly New Mexico, and then in Florida and along the Gulf Coast. Now I'm going to change the chart type from scatter to scatter 3D, and I'm going to use those same heart failure buckets, this time creating 5 different layers, or 5 different Americas. So the top layer is the one where heart failure and obesity coincide. And when I rotate this, we can see this top layer and see that in Appalachia, this is where we have a high coincidence of heart failure and drug deaths. However, down in the Southwest on the bottom layer and in Florida, heart failure rates are quite low while opioid deaths are quite high. And what this highlights is how nuanced a problem this is, that there's no one size fits all solution to tackling either one of these challenges. And that data science can help us tease out the variability that exists among these populations and address patients at a personal level, but address millions of them at a time. So let's move in and now look at how a chief medical officer might be looking at data internal to their organization. So I'm going to come back to the Power BI service and come to the billing dashboard. So I built this with a CFO in mind. And when we click in from the dashboard to the report, I have created some pretty simple metrics. So the number of cases, the cases year over year, the dollars per case, and then billings year over year. Billings year over year is the product of cases times dollars per case. So we see that cases rose by 12% and dollars per case by 7.3%. Down below, I have one small graph that has diagnosis group. So I can select heart disease related cases. When I do that, now we see that cases rose by 13.3% and dollars per case by 2.2%. This column graph over on the right has individual DRGs for heart-related cases. So in this case, I can select heart failure and shock. When I do that, we see that heart failure cases increased by 31% within my hospital system. So very clearly, this is a cause of concern. I also know that readmissions are a challenge, particularly for heart patients. And so I would like to understand what is going on with readmissions. To do this, I'm going to right-click and come to the drill-through page, which is going to take me to readmissions. So now I'm looking at readmissions for heart-related cases, and this line graph shows a very clear trend of readmissions rising over time. So this is just a very simple line graph within Power BI. And then it has a forecast for the next 6 months that also shows a strong upward trend. So this is concerning, but it's not enough data to take really detailed action on. So for that, I'm going to turn to data science, and I'm going to start with the KenSci model bank. So I'm going to come to the login portal, type in my email address, jeff@kensci.com, sign in, and it's going to use Azure Active Directory to bring me into KenSci portal. And I'm going to get to the model bank. And then once I'm in the once I'm here, this is a jump point. The model bank is where KenSci's data scientists have stored all the experiments that they've created. And so here we see a number of different tiles, one of which is the model bank. When I click into the model bank, it now takes me to a page which has a large variety of models to address many of the challenges faced within treatment organizations. So we have high ED utilization, bundled payments, patient cost analyzer, length of stay, fraud analytics on claims, and risk of readmission for different periods. If I come into the risk of readmission for 30 days, I'm going to now look at information, see information about the model, see the academic references that were used as the model was being built. I'm going to look at the model version when it was last trained, get performance metrics on the model, so how accurate a model is it. I can run a new batch of patients and then score that batch of patients. I can also go to GitHub and see the source code that was used to create this model. So we intend that the KenSci platform be one that's very open and understandable. And the other thing I can do is come to the Azure AI Gallery and link right into Azure Machine Learning Studio. And when I do that, it's going to actually create an experiment live in front of us using a 2-class boosted decision tree where I can classify patients as being at risk or not at risk for readmission. And I like to use the Azure Machine Learning Studio because it's easy to see how the experiment was produced. So, one method of collaboration is to work with data scientists who create these analyses in Python or R. We can also then translate those over into Azure Machine Learning Studio. So let me change my view around. So this is the experiment, and then it has been changed to a web service output. So let's go in and look in a bit more detail at the experiment and what happened with that. So here's the KenSci risk of readmission experiment, where we've brought in data, we've cleaned it, we've split that data between data we're going to train on and then data we're going to predict against. We've used a two-class boosted decision tree as the prediction algorithm. We then train, score, and evaluate the model. I can look at permutation feature importance, so which features really drove this prediction. And finally, I can convert to CSV. I can do that either by downloading the output table, or I can generate an access code in Python or R where I can get immediate access to the output from this model. In this instance, however, we're going to use the web service output to work with this data. And so I'll just show you the web service output. I can use this API to connect to my model results from many different platforms. I can also use this Excel add-in to work with the data. So let's now go down to an Excel page where I have the Azure Machine Learning add-in on the side. I'm going to use sample data. So when I click this button, it's going to take these 6 rows and insert them in. I want to move those 6 rows. I should have started in cell A1. So I'm going to move A1. Okay, and now I have the inputs at cell A1 to Q6, and the output will be starting in cell A10. So when I hit predict, it's going to take these 5 rows and send them up to Azure Machine Learning Studio, to our experiment in ML Studio. And we're going to be able to predict on those 5 rows of data. Okay, so it takes those 5 rows of data, it sends them up to my Azure Machine Learning experiment, and then immediately brings down the same 5 rows, but with scored labels and scored probabilities added. So in this case, scored labels are all 0, meaning none of these 5 patients are predicted to be at risk of readmission. But I'm getting instant results about that. And then this scored probabilities is their probability of being admitted. So this is fun, but to make it really useful, I want to use real data. So in this instance, I have an input page that has 5,036 new patients that have just been ingested into my hospital system this week. I'm going to use these 5,036 patients as my data source. When I come back to the model output, when I predict on these patients, it's going to send those 5,000 patients up to my machine learning experiment, and it's going to immediately bring those 5,000 patients down along with their scored labels and scored probabilities. And so now you can see all 5,000 patients have been brought back down, and the third patient is classified as being at risk of readmission with a 90% readmission probability. So now I have this data in Excel in a medium that I, as an analyst, can use very easily. I can also, so I can analyze it right in Excel. I could also put this as a CSV file back into my electronic medical record system, or I could do further analysis in Power BI. So let's come back to the Power BI service and look at the output from this information. So here we have the 5,000 patients. 1,293 of those patients were classified as being at risk, so that's a 25.7 readmission rate. The average dollars per discharge is almost $12,000, so this gives us $15 million at risk for readmission. I can explore in a number of different ways. One, by selecting a hospital group, this group being down in Texas, or I can look at diagnostic categories, so in this case, major organs and systems. And so this is going to show me 436 high-risk patients with an elevated risk percentage of 28.7%. So if I want to explore this more, now I'm going to drill through, and let's take a look at what might be the impact if we can reduce the percentage of readmission. So I'm going to drill through now to the cost mitigation page, and we see for these 436 patients a risk of almost $5 million given this 28.7 readmission rate. Now CMS has said that it should be possible to address 65% of all readmissions, meaning 65% of readmissions are avoidable. But let's say we just reduce by 50% and get down to 14% readmission rate. Then we're going to see adjusted risk of savings of 2.3 million on those 436 patients. And now remember, this is only one diagnostic category in 1 week of patients. So for a large hospital system, you're very quickly talking about tens of millions of dollars. Now, if we're able to get down to a 2/3 reduction, so around that 65%, then we're looking at over $3 million in savings, so quite significant savings. One of the things that our data scientists have learned as they've been working with these models is that the same data that we use to score risk of readmission also works for low ejection fraction risk, as well as mortality risk. So all three of these models run off largely the same data sets, and now we can look at how all three of these risk models are at work with our population of patients. So I'm going to select high-risk patients for low ejection fraction, high-risk patients for risk of readmission, and let's get back to our super category of major organs and system. So when I do that, we're now down to 43 patients, all of whom are at high risk for readmission. And now I can work with these 43 patients. So if I come over here to the patient name, I'm going to see their risk score for all three of these models. I'm going to right-click here and drill through to Stephanie Esmond. So this takes us to the patient risk mitigation page. It's also going to bring us those values for Stephanie Esmond. So we see that she's a 68-year-old female, what her admission diagnosis was, and her readmission issues. We also have actions that can be taken by Stephanie and her care providers to address, to help Stephanie take control of her health trajectory. So if she improves her follow-up compliance, this will drop her by 1 point from 84 to 83. If we can improve medication compliance, this brings an additional 3-point improvement. If we can normalize blood glucose, I mean changing diet, we get down to 77. And then finally, if Stephanie can stop smoking, this brings her down to 75, out of this high-risk bucket and down into the medium-risk bucket. And using data in this way to work with patients and show them in a very palpable manner the control that they can exert over their own health is a really powerful motivator. But there's another thing that we want to do, and that is to be able to integrate very proactively this output into our workflow. So one of the advantages of using Microsoft is that it is HIPAA compliant, and it means it's safe that I'm safe to use many Microsoft tools with this data. So in this case, there are two actions that I can take that are HIPAA compliant. One is to use this Power app, and with this Power app, I can select the 43 patients that we're just looking at, or I could select individual patients, and then I can take two actions. So the first action I can take would be to create a PDF file and store it on my OneDrive for Business, which, as said before, is HIPAA compliant. So I do that. It creates a web page. It accesses my OneDrive for Business and immediately produces this report. The other thing I can do is send an email. So when I send an email, I send it to myself, jeff@KenSci.com. It takes this list of 43 patients and sends it directly to my inbox. So when I come to my inbox, here we see the mails just come in, and I have this list of 43 patients along with their scores. So this means that this inclusion of Power Apps into the Power BI workflow means that we can immediately take action on this data that has been generated via KenSci's model bank. So it means that data science, so we've seen data science can be used by anyone who can use Excel, but secondly, that output can be very quickly integrated back into our own innate medical systems. So let's get back to Bill and what might have happened with Bill had we been able to apply the data science very early on in his history. So if on this first visit, Bill had gone in to see his doctor complaining of discomfort in his chest, had we applied data science and a low ejection fraction model, we would have been able to tell with a very high level of confidence that Bill was going to have a heart attack within the next 3 to 5 years. And instead of giving Bill, vague instructions to stop smoking, improve his diet, and lose some weight, we could have said, Bill, if you don't change the way you're living, you will have a heart attack within 3 to 5 years. And had a much more direct conversation about how Bill can affect what is a very high likelihood that he will have a heart attack. So it's our belief that the application of data science works on a population level, but also at an individual level to help people live better lives and to help healthcare providers operate a more efficient and effective organization. Thank you very much.